Hello and welcome to the UK NEQAS Immunology, Immunochemistry and Allergy webinar series, Mysteries of Myeloma. I'm Dina Patel, I'm Scientific Director of UK NEQAS IIA, and I'm proud to introduce today's webinar session, What is Myeloma and the Patient's Perspective. I'm sure you are all by now very familiar with Zoom, but just a few housekeeping rules so we're all aware of the webinar and the format of today. So speakers will present their slides shortly, followed by approximately 15 minutes of question and answer session with our full speaker panel. All the questions can be viewed by attendees through the Q&A function at the bottom of your screen. And it's really important that if there is a question that you feel you would really like answering, then you have the ability to upvote that question by clicking on the thumbs up icon next to the question. And the more the question is upvoted, the more likely it will be asked at the end of the speaker presentations. Just so that everybody's aware, we won't be using the chat function to answer any questions, and I would ask that you don't raise your virtual hands, please. We are recording this webinar, and we will be sending links to the webinar, the on-demand recording, to all the registered delegates in the next few weeks. Unfortunately, it isn't possible for us to award CPD points directly to attendees, as we're not able to verify attendance. However, registration certificates will be emailed to you, and we suggest for CPD purposes, you could write a brief reflective statement on what you've learned from each of the sessions. So without further ado, I'm delighted to introduce our speakers for today, Dr. Fenella Willis and Mark Scott. Dr. Fenella Willis has been a consultant haematologist at St George's Hospital and has had an honorary senior lecturer post at the medical school since 2004. She is the clinical lead for the myeloma and apheresis services at St George's Hospital, and she has been the principal investigator in a wide portfolio of myeloma and hemato-oncology clinical trials. She is the co-chair for the Myeloma UK Early Diagnosis Steering Group, and she is a member of the board for trustees for two charities, Myeloma UK and the Full Circle Fund. Mark, our patient perspective speaker, was diagnosed with myeloma in August 2018. He has battled through chemotherapy, stem cell transfer, and a long, slow recovery back to full health. He's now in complete remission, and the myeloma has been undetectable for almost 2 years. Mark will provide an invaluable insight into his patient journey. So if I can ask Fenella to share slides, please, Fenella, and then I'll hand over to you.
Fantastic. All right, hopefully everyone can see my slides. So I'm really privileged to be able to talk to you today in the first of our series of 5 webinars. The importance of this webinar really is to set the scene for the subsequent webinars, which will be much more laboratory based. Our aims today are really as to cover what myeloma is, really the impact of delayed diagnosis, and certainly the patient's perspective on that will be very important. The typical treatment pathway, monitoring post-treatment, and understanding the patient's experience, so Mark's experience and journey through his myeloma diagnosis and treatment. So, what is multiple myeloma? Well, it is a B-cell malignancy, and it's derived from plasma cells, and plasma cells are normally the body white blood cells that produce antibodies in the body, and they're normally found in the bone marrow. So what happens is that in myeloma, as the number of malignant plasma cells crowd out the bone marrow, there is interference with the normal development and function of cells within the bone marrow. And that can lead to some of the symptoms of anemia and other effects we see in myeloma. In addition to that, there is a gradual accumulation of myeloma cells in the bone marrow, and the production of the M protein can have direct effects on the bone marrow and indirect effects on the blood, the skeleton, and the kidneys. And that leads to a lot of the symptoms that we see in patients. I think it's always useful to have an overview of where myeloma sits in the series of B-cell malignancies that we see. And as we know, as a B cell develops, a B cell is important in the humoral system and the adaptive immune system. And actually, myeloma affects the most mature cell in that system. So it's the terminally differentiated B cell whose sole production is the production of antibodies. And that leads to, obviously, the ability to detect myeloma through detection of the M protein. Now, putting myeloma in context of other blood cancers or other cancers, when we look at blood cancers, blood cancers are the 5th biggest group of cancers, but often their voice is not heard, partly due to the fact that it is a group of very different cancers within that group. But obviously it sits below the big 4 cancers of lung, breast, prostate, and GI. But multiple myeloma in terms of blood cancers is the 3rd most common blood cancer, and it is the biggest killer of patients because of the fact it is often diagnosed in elderly patients, and it is often, we know it is an incurable condition, so we can manage it and we can treat it. And actually in many patients, it is more of a chronic illness rather than, obviously an acute illness, but we are still unable to cure it. Approximately 70% of patients with myeloma are diagnosed with it over the age of 65, but it's important to remember that 30% are below the age of 65. And actually, often the difficulty is in picking up patients who are younger, partly because GPs and secondary care physicians often don't think about myeloma developing in a younger patient. And in the UK, approximately 5,700 patients are diagnosed each year. So what are the risk factors? And I think it's important to understand the risk factors, because also that sort of leads us on to thinking about ways in which we can hopefully pick up or potentially screen at-risk populations for myeloma. So we know that myeloma is more commonly seen in older patients, and that there's a slightly higher incidence in men compared to women. Environmental factors are hard to prove, but what is very clear is that there is definitely a higher incidence in the Afro-Caribbean population. It's almost twice the Caucasian population. There is definitely a family link. So if we look at families, there are certain families that will have an increased frequency of B-cell malignancies within them. And all patients with myeloma will have had this pre-existing condition called monoclonal gammopathy of undetermined significance, or MGUS. Now, we may not always pick that up in a patient with newly diagnosed myeloma. They may have gone through that phase without it being detected, but they will have all had that at some point. Now, myeloma, many of you may have seen this slide before. Myeloma is sort of currently an incurable blood cancer, and it is typically characterized by these series of remissions and relapses. There is an early phase where a patient has this pre-existing MGUS or indolent myeloma, and over a period of time, often years, the M protein and the malignant clone will increase to a point where a patient will become symptomatic. At the point when they become symptomatic, obviously they start their first line treatment, and we'll see a rapid fall in their M protein in response to that first line treatment. And hopefully they then enter a phase of remission. And we know that the first line treatment is probably the most important treatment because we tend to get the best responses and the longest remissions from that first line treatment. At some point, patients then go on to relapse, and we know that myeloma is a recurring disease in terms of relapses and remissions, but typically the duration of those remissions between each relapse decreases as we go through the illness, until ultimately we end up with a phase where there is a fairly resistant disease which is difficult to treat, and the patient succumbs to that illness. So how does myeloma affect the body? Well, it's always important to think of it as a multi-system disorder. It can affect the blood, and that can be in relation to anemia. So as I mentioned already, because the plasma cells crowd out the bone marrow, often the other residual blood cells within the bone marrow are affected and reduced. And that can lead, as I say, to anemia, but it can also lead to lowering of the white blood cell count and lowering of the platelet count. As a result of the bone marrow or the plasma cells preferentially producing this monoclonal M protein, the other normal clones of plasma cells are reduced. And as a result of that, we often see this secondary immune suppression, which leads to an increase in infection. And we can also see when the M protein from the plasma cells is very high, interference with the normal clotting, so risk of bleeding or bruising, and particularly when the M protein is very high, symptoms of hyperviscosity due to the blood becoming very thick and not therefore getting through the tissues and to organs as efficiently as it would normally. Renal problems are very common. That may be at diagnosis as a result of a high M protein and what we call karst nephropathy, but it can also be seen in other plasma cell disorders which are not classified as myeloma, i.e. MGUS. We can see deposition of the light chain in the kidneys causing conditions such as amyloidosis or light chain deposition disease. And then finally, it can affect the bones, leading to lytic bone disease, osteopenia, and leak of calcium into the blood with hypercalcemia. So how do we diagnose myeloma? I think it's really important to think, actually most patients will be coming from primary care to secondary care for their diagnosis. In primary care, the key investigations that a patient will normally have when they're unwell include their full blood count and blood chemistry. And this is where the problem lies, in a sense that if a GP doesn't suspect myeloma, the specialist tests of serum protein electrophoresis and urinary protein electrophoresis will not be requested. And that can in itself lead to a delay. We know if we look at the biochemistry and the full blood count, that actually one of the earliest signs of something happening is that anemia often develops very early on in the disease. But actually problems with the kidney function and calcium are typically seen very late in the disease, and therefore are not a very good way of picking up patients with early stage disease. Once the patient hits secondary care and seen by their hematologist, obviously we'll be doing additional blood tests. Most of these will be to look at prognostic factors or prognostication of the patient. So we will be looking at things like beta-2 microglobulin, albumin, and LDH, because this will be used when we use the risk stratification of the RISS system to look at whether our patients fall into a type 1, 2, or 3 group in terms of their prognosis. To confirm their diagnosis, however, we need to go on to do further tests, including a bone marrow biopsy, which will pick up the clonal plasma cells within the bone marrow. And typically for myeloma, we need to demonstrate that that clonal plasma cell population is in excess of 10%. And then we'll go on to do imaging to look at the skeleton, the central part of the skeleton, which normally will have active bone marrow, what we call the axial skeleton. We typically now use cross-sectional imaging, partly because the pickup of lytic deposits is much higher on cross-sectional imaging, and it also allows us to look for disease outside the bone marrow or extramedullary disease. And with the combination of these investigations, we can hopefully come to a conclusion and a diagnosis. I've obviously mentioned about the M protein, and obviously patients may have a different monoclonal protein. These are immunoglobulins. In malignant plasma cells, these immunoglobulins may not have a function. They may not be complete. There may be only light chains, or there may be complete immunoglobulins such as IgG or IgA. And in some patients, in a small group, we may not be able to pick up any secretory protein. I talk about myeloma investigations or specialist tests because obviously the laboratory is pretty key in this. As I said to you, obviously it's very important for the GP to suspect myeloma, but actually what's also very important is for the laboratory to help and give information about myeloma to the clinicians. So when abnormal tests are picked up in the laboratory, we need to have that communicated in a rapid way, either to primary care or to secondary care, to pick up and speed up the transfer to clinic. So finally, having got all our laboratory tests together and our biopsy, we go on then to diagnose myeloma. And I now want to pass over to Mark, who's going to really explain what it was like to go through that journey to that diagnosis.
Thank you, Dr. Willis. Good afternoon, everybody. It's lovely to be here to speak to you all. And I'm going to talk you through my myeloma journey so far. And it kind of starts in January 2018, where I kind of refer to this as my threesome phase, because my life involved myself, my wife, and misdiagnosis. Now, in January 2018, I presented at the doctor's with a bit of a bad back, a sore hip, and I put that down to a little bit of over-enthusiasm with trying to get fit again and getting back into jogging, etc. And initially, after some x-rays, I was told that I had facet joint wear and tear. And to be honest, I've never heard of facet joints. And it didn't kind of sit well with me because this seemed to be the consequence of over-exercise. And like a lot of people, from time to time, I get a little bit guilty about my weight and do exercise. I'm not a serial exerciser though, so I don't know why I had wear and tear to my facet joints. As we went on through early 2018 though, things weren't improving. I was limping more and more. I was having increased amounts of pain managed by different painkillers. And we moved on to potentially you might have a slipped disc, you might have some kind of bulging disc in your spine, potentially a trapped nerve. I was in and out of A&E, I was in and out of my GPs. The one consistent message was, certainly with the idea of back problems, was that it's going to get worse before it gets better. And absolutely, it did. In that early part of 2018, I was seen by a variety of healthcare professionals. I saw at least 3 of my GPs at my local surgery. I went to A&E a couple of times after collapsing at home. I was seeing an NHS physio and also a private physio because I wanted to be proactive about it, because I did believe that we would be able to fix it. I actually even saw an osteopath, which I suppose with spinal fractures that I was developing at the time was probably not the best of ideas, hand on heart. And this is how I sum up the first part of my 2018. This is a picture that I put onto Facebook in April 2018, so it's actually more or less 3 years old. I was on so many different painkillers and different opioids to manage the pain that I was told was going to improve with treatment. And unfortunately, that wasn't happening. But at this point, what I do like to make clear, we're now 5 or 6 months into what was a quite horrific, when I look back, period of my life with increasing amounts of pain. I was trying to stay in school and carry on working as a secondary school teacher, but it was getting increasingly difficult. But I always use the horses and zebra analogy with this. If you hear hooves, you think of horses, you don't think of zebras. So when I was going to the doctors and saying, my back hurts, my hip hurts, it's exactly what Dr. Willis has said. The myeloma did not come to mind. They were thinking about different conditions that may affect the back. And at that time, I didn't have any testing that would indicate myeloma at all. I did then have an MRI, which I pinned a lot of my hopes on because I hoped it was going to identify exactly what my problem was. And unfortunately, that came back inconclusive. So when we get to mid to late July, I'm completely bedbound by this point. I'd finished work and had to give up work in late May because I was physically unable to walk properly at that point. I was advised to spend some time in bed and rest. That was May the 18th. From there, it just got steadily worse until probably late June. I was probably bedbound for about 5 to 6 weeks. Not very much was happening. I'd had some inconclusive blood tests as well. And in the end, it was my wife who decided to march down to the GP's or drive, because it's quite a while away, and get a home visit organised. And then on the 30th of July, Monday, the 30th of July, 2018, so more or less 7 months of these problems, I was sent to A&E and kept overnight. And I realised I no longer had a bad back when the doctor insisted I needed to have a finger shoved up my bum. And I thought, well, that's clearly not my back, is it? And then the following day, after some extra additional blood tests, and actually on Wednesday, the 1st of August, 2018, was the first time I heard the words myeloma. And it sounds ridiculous to say when someone is telling you that you have an incurable, life-threatening cancer. I was actually relieved because we were so fraught with the not knowing what was going on. When they finally told us I had a treatable condition, I have to say I was actually, sounds strange to say, I was pleased to know that I had myeloma because I knew we could move on and be treated. Thank you.
Yeah, thank you, Mark. Unfortunately, that is a story I've heard quite a few times. People seem grateful that they've got a diagnosis. I think that we've heard from Mark really is the impact of a delay in diagnosis. What I want to really outline is really how big a problem that is. We know that 40% of myeloma patients have a significant delay in their diagnosis. And unfortunately, that's not only in primary care, but it often is in secondary care as well, partly because patients present with very vague and non-specific symptoms, and they often get referred to other secondary care outpatient departments for investigation of anemia or investigation of what is suspected as either rheumatological or orthopedic problems. Now, 20% of those patients that have a delay in diagnosis unfortunately succumb to their illness very early on because of the fact they present with very late stage disease. We know that 32% of patients are diagnosed through the emergency route, and actually one of the things that I'm sort of aware of is that over the last year, actually it's probable and very likely the percentage of patients presenting through the emergency route has actually gone up as a result of the COVID pandemic. Why is that important? Well, patients diagnosed through the emergency route have a significantly poorer 1-year survival, which is 53% compared to 82%, and a significantly poorer 3-year survival. And that's purely down to the fact that they are presenting often with very late stage disease with multi-organ involvement and considerable morbidity. So how do we, what other facts do we know about delayed diagnosis? Well, as I say, myeloma has the longest pathway for any cancer in terms of first symptoms to diagnosis, with a median of 163 days, which is phenomenal. 1 in 5 patients go and see their GP more than 5 times before a referral is made. And that's not because the GPs are not good, it's just that actually it's really difficult for GPs to pick it up. And the commonest symptoms are non-specific and very frequent problems that come to the GP. So fatigue, infections, back pain, which the GPs obviously see on a daily basis. And obviously it's trying to pick out the patients that have something seriously going on from the numbers that come through general practice. So the other thing to be aware is that GPs actually only see patients with myeloma very infrequently. Probably they see one new diagnosis of myeloma about every 3 years. As I say, the presenting symptoms are very common. The awareness is very low, and in the community, the awareness of myeloma is extremely low. I'm frequently asked whether it's a skin cancer, and even within the hospital, there can be misdirected patients directed on the wrong pathway because of the awareness being low. And we have to do a lot to improve the awareness, both in the community and within the hospital environment. And obviously, late presentation is linked to increased problems with complications and morbidity and mortality. Does delay matter? Yes, it does matter. It matters because end organ damage is done, which is sometimes irreversible, and that be bone disease, spinal deformity, patients ending up on dialysis, things that are all preventable if we can pick up the diagnosis early. It matters because patients get hugely frustrated and lose the trust in the doctors and the system. It takes 7 months to be diagnosed. By the time you get diagnosed, you just feel, actually no one is listening to you, that no one really is taking your symptoms seriously. And it does matter because of this excess mortality. So we really have to focus on how we can improve this. But as I've outlined, there are considerable challenges because of inconsistent awareness and access to the full range of diagnostic tests. So one of the things that we're working with primary care and trying to work very hard to do is to improve awareness. But one of the things that consistently comes up, and which I can see as a problem, is that actually GPs don't have necessarily order sets for, if they suspect myeloma, they have to tick one button, and on that, tick, all of the required tests for myeloma are done with one hit. They have to think about the fact that they've got to do the full blood count, they've got to do the renal function, they've got to do the bone profile, that they've got to do the serum and urine protein electrophoresis and light chains if they've got that available. And of course, it means ultimately that some of those tests are missed. And if you don't have a complete set of tests, you potentially miss patients. In 2017, we did a survey to laboratories with UK NEQAS, and really that was to try and find out, obviously, what was happening within laboratories about testing for myeloma, reporting for myeloma, and also flagging abnormal results. And what is very important is that we picked up actually that there wasn't consistent reporting, there wasn't consistent flagging of abnormal results. And obviously that's a missed opportunity because it allows for GPs or secondary care physicians to be alerted to an abnormal result earlier and potentially allow for that patient to get to the right place at an earlier page and get their diagnosis more quickly. So, part of our work over the last couple of years has been really focusing on how we can try to improve that, improve the education through the laboratories, improve the awareness and improve the systems to try and make this less of a problem. Once we have our diagnosis and our patient, in front of us, obviously the next stage is to make treatment decisions. And I'm not going to go into huge details about all of the different treatments that we provide, but I think it's useful to have just an overview really of what is important in when we are making a treatment decision. Okay, so we make a diagnosis of myeloma, but that's only part of the story. We have to look at the patient, the patient, how frail they are, what their age is, what their performance status is, what their disabilities might be, and what are other medical problems they may have or comorbidities they may have. We have to look at the effect of the myeloma disease on their body and whether that may impact on terms of how we may be able to treat them. So looking at, obviously whether they have renal impairment, and whether they have significant bone disease, whether they need intervention from the orthopedic team, prior to us starting chemotherapy treatment. We then have to assess their risk, and that's really important in being able to give a prognosis to a patient in terms of whether we think their disease is going to be relatively straightforward to treat, or they may have a very resistant or high risk disease. And that involves cytogenetic testing, and also involves us doing a prognostic scoring, or the ISS scoring. It's important to look at previous medical history and patients' previous exposure to treatments, and particularly if they've been exposed previously to chemotherapy treatments. And we start to put this whole picture together to be able to make a decision about what we're going to do in terms of treatment. You may have heard of things like the CRAB criteria or the SLIM criteria. So when a patient is diagnosed with myeloma, that is only part of the story. We have to confirm that they are actually symptomatic from that myeloma, and that they don't have what we just call smoldering myeloma. So smoldering myeloma is where we've got a histological diagnosis of myeloma, but it's not actually currently causing the patient any symptoms, and it's not causing the patient any end organ damage. So the CRAB criteria looks at anemia, bone disease, renal disease, and hypercalcemia as markers of symptomatic disease. In 2016, we started to look at actually some of the patients with high-risk smoldering myeloma who we knew were at such high risk that we needed to treat and not wait for them to become symptomatic. And this is what we call the SLIM criteria. And these patients have myeloma-defining events. So if they have a bone marrow that shows 60% involvement with plasma cells, or they have a significant abnormality in their light chains with a ratio of the abnormal light chain to the normal light chain of greater than 100, or they have more than one abnormality on the MRI scan measuring greater than 5 millimeters, we know that there's an 80% risk of that patient becoming symptomatic from their myeloma in 2 years. And why wait 2 years until a patient gets problems? It's much better to treat these patients immediately. So this is a complicated, obviously just a quick overview of the treatment pathway. So when we see a new patient diagnosed with myeloma, the first question is, are they fit enough to be considered for an intensive pathway and a stem cell transplant? If the answer to that is yes, or we think it might be, because sometimes there are patients that might sit on the border, particularly since we still, these days, we will be doing stem cell transplants in patients often in their early 70s if they are fit. We will be treating typically with a triplet regimen. So that's 3 drugs, which includes usually a proteasome inhibitor, an immune modulatory drug, and a steroid. We'll get the patient into remission. We will then go on to a high-dose melphalan autologous stem cell transplant. And now all patients are going on to a maintenance. That's only fairly recently, but in clinical trials, we've been looking at obviously the role of consolidation and maintenance for some time. If the patient is not fit enough for a stem cell transplant, and as I mentioned, obviously 70% of our patients are over the age of 65, we will then obviously be assessing their frailty and their comorbidities so that we can assess whether they would be fit potentially for a 3-drug induction, whether they're intermediate in their fitness and we might consider 3 or 2 drugs, or whether they're frail and we might need to adapt the dosage of their drugs, potentially only give them 2 drugs, again with very similar combinations of drugs. Back to Mark now in terms of his patient treatment journey.
Okay, lovely, thank you. In terms of the issues around delayed diagnosis, and this is going to sound very vain, the one thing that continues to vex me continually is the fact that I lost 6 inches of height as a consequence of my delayed diagnosis. Over the course of that first half of 2018, I suffered 7 spinal fractures and a collapsed vertebrae. So, and I'm not being sizist or heightist in any way. I was a lovely 6'1" at the start of 2018. I'm now about 5'7". So with very long, normal legs, but quite a scrunched up upper body. And that's the one thing, and again, it's a vanity of mine, that height loss was the one thing that really, really annoys me, which probably shouldn't, considering I've got incurable cancer. But anyway, we move on to the 4th of August, 2018, which is my wedding anniversary, actually. It was my first day in Manchester Royal Infirmary, where I met Alberto Rocci, who was my consultant, personal legend and hero of mine. And they outlined all the different things that might happen as a consequence of my treatment. All kinds of side effects that I would potentially suffer that are on the next slide. And to be honest, I didn't really care at that point. I was in so much pain that the hip and lower back pain was now pain that would result from any movement of the spine whatsoever. So I was effectively just could only lie on a bed and not move. So I didn't really care what the side effects were. And they put me on a regime of Velcade, thalidomide, and dextromethasone. And to be honest, I think I was very lucky. And when I speak to other myeloma patients, I can see sometimes they're giving me a little bit of side eye because I had a little bit of neuropathy from the Velcade that was masked by the amount of morphine I was taking. I had some insomnia from the dextromethasone, but that was fine because I binged watched Brooklyn Nine-Nine, Big Bang Theory, Game of Thrones, got through a lot of television on the iPad in hospital. I think the biggest side effect was actually at times I did become a bit of a pain in the backside. I was very grumpy, not being able to sit up properly, not being able to get out of bed at all for nearly 2 months. And Emma, my wife, says, no, you were a model patient. She's just being nice. I really wasn't. So in January 2019, I'd finished my chemotherapy. I was back home. I was mobile. I was confined to a hospital bed in my dining room downstairs. Didn't have the strength to walk up the stairs yet. I was using a wheelchair a lot and a Zimmer frame. But we'd already agreed at this point that I was going to have a stem cell transfer. And this sounds a little strange to say. This was the first time I felt like I really had cancer because I felt like a cancer patient. I knew my hair was going to fall out. I knew I was going to be walking around hospital with a drip. For myeloma patients, this is a big part of my patient experience that I talk to them about. There's a lot of fear in the community. There's a lot of anxiety about stem cell transfer and the physical effects of it. And it certainly wasn't a picnic by any means. And the process to me was almost magical. This was the several hours they spent extracting the millions and millions of stem cells they needed for my treatment. And my 2 weeks in hospital, this is the calm before the storm. This is before the hair was going. And that's my Jedi robes that I wore to try and power through. But I was in hospital for 2 weeks for my stem cell transfer and came out at SCT plus 12, I think it was. But for me, again, we sat through those side effects and, you know, the chance of dying effectively, and signed off on those and didn't really care. I knew I was going to lose my hair. I wasn't worried about that. I'd always wanted to know what I'd look like if I was bald. But the one thing that I thought in the back of my mind is if I have this treatment, my remission will be deeper and longer. And effectively, in my head, the alternative to not having a stem cell transfer was I will likely die sooner. And at the end of the day, well, frankly, I don't really want to. I have teenage children. I want to be around to walk my daughter down the aisle if she chooses to get married in a decade or so. I want to be there when my son does the same thing, who's a few years younger. I want to enjoy a long retirement with my wife in 10, 15 years or so. So for me, this was a no-brainer. I was going to do this no matter what. And my stem cells are frozen somewhere in Manchester Royal Infirmary, and I'll use them again for another one if I'm allowed. And this is kind of my mindset. I was happy to suffer now, and I don't do ill very well. Or as I said, I can get very mad about it, but live the rest of your life as a champion. That was my mindset. Get through this now, and things are going to get a lot better, a lot quicker. And they did, to be honest. They absolutely did. And I had a kind of a personal philosophy for this. On the 1st of August, when I was first heard the word myeloma, I had about a 5-10 minute spell where I was a bit fed up. I was down. I thought, why me? I'm not unhealthy. I'm not a smoker. I've got a reasonably good lifestyle. About 10 minutes, I had a little cry and I was a bit upset. And I was waiting for my brother and my wife to arrive to tell them what exactly was wrong with me. And I thought, hang on a minute, no, we're not doing it like this. We're not going to be maudlin. We're not going to be down about it. We're going to be relentlessly positive about it. There wasn't a lot to be positive about at that point, but we were going to attack this with positivity all the way. This was going to be my experience. First day in MRI, they told me I was having a bone marrow biopsy. Every other patient around me on the bed said, this is the most awful experience. It's so horrible. A nurse offered to sit and hold my hand. Before they did it, I was terrified. When they actually did it, it was fine. The second time I needed one, I had two, one after the other. And that was fine. So I wasn't going to listen to other people's experiences. I wasn't going to have, it's like this, it's like that. It was going to be my experience. Now, there is no medical basis to this next sentence. So I defer to Dr. Willis for that kind of thing. But for me, alongside the treatment, it was attitude and treatment. It had to be lots of attitude alongside the treatment. I was not going to be fed up about it in any way, shape or form, as I said. And you know what? I have an incredible network of friends, colleagues who helped me with that as well. The second thing that I really focused on was small wins every single day. Nothing life-changing. I wasn't about to jump out of my bed and run a marathon or anything like that. But every single day I was going to do something that was going to count towards my recovery. And without wishing to be lower the tone, that might be being able to go to the toilet. That was able to being able to lift my lower body off the bed so they could slide one of those cowboy hat things underneath so I could go to the loo. It was little tiny things like that. It was sitting in the chair next to my bed for 15 minutes a day and physically shaking and in pain with it, but wanting to do something. And every night when I lay in hospital at the end of the day, I would lie there and think, right, okay, where are my wins today? What have I done that's made me better? And like I say, what I was lucky with was the fact that I had a really great support network around me. So I have a wonderful family, my wife Emma, my children Molly and William. And these are just a couple of the little things that I did. The first picture was me standing up for, that was about the second or third time I've been out of my bed in a couple of months and being able to support myself. You can just see the back brace I had to wear in order to do that. Visits from my family, my wife being there all the time to support me. Again, obviously I had to use a wheelchair quite a lot. The children weren't supposed to be allowed into the myeloma ward because of risk of infection, but we did manage to slip them in just for a very, very quick visit. And finally, this was a huge milestone for me. This was, and I was a bugger for this with the physios. I wanted to count my steps every day. When I was able to get out of bed and walk, how many steps could I do in a day? And this was the first day I got over 100. I made it to the day room at the end of the ward where the television was, and I was absolutely delighted. Had to sit there for half an hour to recover before I could walk back. But it was those little milestones that made the journey a little easier. Now, obviously, after my stem cell transfer, I came home, had a long and slow recovery. Now, I'm a Star Wars person. I'm not a Star Trek person, but this spot quote sums it up beautifully. It's life, Jim, but not as we know it. So obviously, my life isn't the same anymore. It was never going to be the same again, but it's about as close to normal as it could possibly be. Again, this is my hospital bed downstairs in my dining room. This was me practicing not having to hold my Zimmer frame to walk around the house. And again, building that up slowly and having that patience to do that. But at the end of the day, the multitude of minor ailments and tics that I have, I don't really mind at all. I do have an aching back now that I'm back at work. My back is sore at the end of the school day. I do occasionally limp around. I do still suffer with the neuropathy a touch, not too bad, get very tired. Something I didn't expect to be a side effect was getting very emotional. I cry at Andrex adverts and things like that sometimes, which is a little bit strange. But all of that just tells me that I'm alive. Now, 557 days from March the 18th, I had off work. I was off for 557 days. Very lucky as a public servant that my school supported me through that. When I went back to school for the first time, this was my first visit to school. You can see my height loss there. I used to tower over those boys. The boys in school had raised close to £5,000 for cancer charities. Initially, they said we want to raise money for cancer. And then later, when they knew what my cancer was, with myeloma. They raised about 3,500 for Myeloma UK. Just that support from the school community was amazing. So I've managed to find a couple of cheesy promotional pictures that school uses of me. So I'm now back in the classroom. Like I say, I've rushed home today to take part in this, having taught 4 lessons today. And I'm absolutely delighted that I was able to do that, because, you know, you can get through the treatment of myeloma, and you can have a normal existence as close as possible. And one of the things I always try to do is I always try and look for my cancer perks. What are the good things that have come out of this experience? And there actually are several. That one's now redundant because of lockdown. I've put all of that weight back on, but I did lose 2 stone, which at the time I was absolutely delighted about. What it did do as well is we've always been a close family, but having the spectre of something like this hanging over you does bring you closer together. And genuinely, I did start to think about my own behavior. I'm probably, and it sounds strange to say, I'm probably happier and healthier than I was for several years post-treatment. And the things that were on my bucket list, the things I would do when I retire, they've been brought forward. So we'll be doing those as best we can over the next decade or so. And I think from a personal perspective, what you quickly find is you can cope with a lot more than you think. People say to me, oh, you've done amazing to get through this. But I think anybody would when confronted with something like this. And you are stronger than you think as an individual. And also, alongside that, you quickly find, and I found, that you are more popular, more loved and more respected than you think by family members I've not spoken to for years, colleagues at work. Students were sending cards and cakes into hospital for me and things like that. And all of that just makes a difference. And all of that helps massively with getting through an experience like this. And just for me, and this is really for any fellow myeloma patients who are worried about the process and what happens, I think you need to become an expert on your condition. And listening to Dr. Willis today has improved my knowledge even further. And always be positive. And remember that there is support there for you all through all kinds of different organisations that helped me. Macmillan especially are unbelievable, Myeloma UK, and even the power of Facebook, positive power of Facebook anyway, through the Myeloma Facebook support group. And for me, you know, as I sit here now, I feel blessed to have gone through and got through that experience. I feel relatively unscathed. Yes, I'm a little bit shorter than I was before. And yes, I do have some physical ailments, and I've had to give up my dream to play football for England. But basically now what I have to accept is that I have a new normal in my life. And it's not going to be the same as it was before, but it can be just as good and just as rewarding as my life was before. And as a history teacher, as a historian, I always like to finish with a quote from one of my favorite presidents, Dwight Eisenhower. And I say this to myeloma patients that I meet. What counts with this situation is not necessarily the size of the dog in the fight, it's the size of the fight in the dog. So thank you very much for listening to that. And I'll hand back to Dr. Willis. Thank you.
Thank you, Mark. That was fantastic. I'm going to very, very briefly, because I know obviously we need a bit of time for questions and answers, just to go through basically the importance of monitoring through treatment and also patients in remission. I know my fellow speakers will be able to talk a lot more about this in subsequent weeks. But obviously patients, when they go through their treatment, you know, every time they come back to you after a cycle of chemotherapy, their first question will be, what's happening to my paraprotein, or what's happening to my light chains? Because we know, and they know, that's a way that they can monitor their response to treatment. So we use it as a marker of response. You know, the International Myeloma Working Group criteria of response is based on improvement in protein. And we need to achieve partial, very good partial response or complete responses really to go on to stem cell transplants. So it is an important thing that we need to monitor. Our ambition, however, is to get better responses than just complete remission, because we know actually from a lot of data, if we look at patients, if we really want to give the best outcome and the best disease-free interval, what we're looking for is MRD negative disease, and that is really looking at a much more sensitive techniques, including flow cytometry, to demonstrate that there's no evidence of ongoing disease. But going back to the laboratory, I'm just going to quickly say in terms of monitoring, just a quick example of a patient of mine in terms of monitoring, because I think it just highlights an issue around sort of clonal evolution. And in fact, what you see to begin with may change as you're monitoring a patient. And that's really very important. You still get the breadth of your tests when you're reviewing a patient. So this patient of mine was diagnosed in 2005, and actually at diagnosis had a large IgA kappa paraprotein, which we can see both by the table and on the immunofixation. This patient also had some kappa light chain in her urine. She did extremely well. She was treated with actually a combination of induction. In those days, it was VAD chemotherapy. She didn't respond so well to her first-line therapy, but it had CTD and went on to an autologous stem cell transplant in 2006, and actually had a really durable remission. But the first hint of her disease coming back in 2017 was with just her bench Jones protein in her urine and a rising kappa light chain, without her paraprotein. And that's what I always say to people, it's really important that you're looking at both markers, because you don't always get exactly the same intact protein come back at relapse. And if you're not looking for all of those markers, you may miss it. So it's just really as a little flavor in terms of monitoring, it's really important that we get all of those tests together when we're assessing the patient. All right, so just in conclusion of what we covered today, hopefully you've got an understanding of the impact of myeloma on the patient, the importance of early diagnosis in the prevention of morbidity and mortality, an understanding of what myeloma is, how it's diagnosed and monitored, an overview of the treatment for patients with myeloma, and why communication of results between the laboratory and secondary care might impact on the patient journey. And at this point, hopefully I'm going to hand you back to Dina to obviously pick up.
Thank you, Fenella. I would like to just say thank you ever so much to both of our speakers today, Fenella and Mark, and to everyone at UK NEQAS who are making this series of webinars happen, and to everyone for taking the time out to join us today. It's been absolutely fascinating. I hope you've all enjoyed the sessions and benefited from what's been said today. So this was the first in a series of 5 webinars we're putting on over the next 5 weeks. You'll see on the screen now the details of the other upcoming sessions. In the final webinar on the 26th of May, we will be picking up all unanswered questions, as I've said, as well as having an open discussion with the speaker panel around any cases or results that attendees might want to submit for discussion. And finally, UK NEQAS is active on Twitter and LinkedIn. So if you do social media, I'd encourage you to seek us out and follow us on these platforms. I'd like to thank everybody for attending today's session. And once we do close this session, there will be a very, very short survey for you to complete. So we would appreciate your opinions to help us improve future webinars. So thank you once again. I'm sorry we've overrun by a few minutes, but it's been an absolutely fascinating session, and I hope you're able to join us next week. Thank you very much. Stay safe. Thank you.